Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, and welcome back. I'm Dr. David Kaufman. I'm here with my friend and colleague,
Hi.
Eileen Ruhoy. We're doing a Zoom today for scheduling conflicts. How's that sound? Okay.
We couldn't find a time that we can both meet up at the studio, but we wanted to make sure we recorded one of these episodes. So
right. So this may feel a little different. We'll see how it plays out. Okay. So you want to introduce the topic today?
yeah, we decided to discuss neuropsychiatric symptoms and how they are very much a part of chronic and complex illness, and they can also be a part of the reason why our patients have such a difficult time being taken seriously by many of the doctors they see. So we felt it was an important topic to sort of dive into a little bit and see how we think about it, how we approach it, what we do about it, and how we guide patients on it, importantly.
Yeah, it's just really, really important. I mean, I think we spend a lot of time on these episodes and also in the office and on telemedicine appointments dealing with, POTS and SIBO and leaky gut and mast cell and EDS. And we do touch on some of the stuff we're about to talk about, but it's crucial information and a crucial kind of issue that exists there in the background all the time.
Yeah, I think importantly, patients get, we always say that they're told that their symptoms are related to anxiety or depression or stress or some other mental health diagnosis, and it gets put on their chart. And as you know, once something is put on the chart, it's very hard to get it removed from the chart.
Right.
And I think that complicates when patients go to seek care and the doctors pull up their chart and they see, generalized anxiety disorder or depression, even if it's like not otherwise specified. Or worse, sometimes some doctors just take it upon themselves to sort of, really just label with a true, psychiatric diagnosis like bipolar or OCD. So I think that can complicate sometimes how their doctors perceive the symptoms that they're reporting.
Yeah, I think it's unfortunate more than sometimes. I think it's very frequent. And I want to emphasize a point you just made, Eileen, that, one of the great traumas of electronic medical records and Epic in particular is that at this point, what you say in New York, what a hospital says about you in New York, it will show up on your record in New Mexico and in California and in Montana and in Idaho and every single facility you walk into.
For decades, forever.
Yeah, forever. And it's a terrible thing. It's as if, everybody says HIPAA, privacy, and yet it is the most profoundly unprivate situation. And all you need is one third year medical student to write into the chart, patient depressed, patient anxious, and it's there forever. And now, as our patients know even better than you and I, the moment they walk into that ER and they say, I have fatigue, it immediately is equated to depression or anxiety. Yes. Okay. And then add in, if ME/CFS gets into the record, that just compounds the whole picture.
Yeah. And so sometimes I think, I think when somebody puts anxiety on the chart, I think sometimes it is well-meaning, we should point out.
Yes.
Because I don't deny that there's a level of anxiety or even depression that's associated with our patients and their chronic illness. But sometimes, first of all, I mean, it's situational to some aspect, right? I mean, I think that's understandable and completely normal reaction. I mean, I have patients regularly cry to me about how troubling this is to their lives, that they wake up every morning and they think, oh my God, I have to deal with all these symptoms again. I mean, that would induce anxiety and sadness in just about everyone. So I think that there's a normal secondary reaction of anxiety and depression and maybe some other things. So to label it, I don't necessarily think is always with the intent of, making it hard for patients to get care. But as we know, a lot of doctors just sort of see this, that's the primary diagnosis. You're
Right.
anxious, and that's why you have these symptoms. There's really no other explanation, basically. And it just shuts down the conversation, and that's my concern.
Right. No, I agree.
Once especially a new doctor sees on the chart that, oh, patient is anxious and depressed, well, that just sort of colors, I think, everything he or she might see in the patient when their patient is trying to describe symptoms and concerns and how they're feeling. So so I think that I do want to point out that I think sometimes it was well-meaning initially, but it ultimately it does not serve in the best interest for the patient. And that's always my concern, especially since access is so hard for these patients.
Right. Right. Yeah. I mean, I think in truth, it would be almost abnormal for our patients not to experience depression and anxiety. I mean, this is, there's a situational is the term I think the psychiatrists use. But how could they not be? Their lives are upended. Have lost or are losing years and years and years of life of everything. I mean, I sometimes think about it with, when I meet a 25-year-old patient who's been sick for 6 years, and I think 6 years, 19 to 25, that's just mind-boggling to think of those years are lost, And I think you and I have off camera or off episode talked or mentioned that I have some patients who I'm astounded by their ability to maintain their optimism and hopeful outlook and just sense of humor. It's like, God, I want some of that. How did you do that?
They're inspiring.
Give it to me.
I know. And I feel like if they can go on day to day, then so can I, right? So it motivates me to help them even more so. And so, yeah, I completely agree with that. And I also want to point out that not only is it situational, but we also talk about how there's a clear, like, biologic undertone to a lot of these mental health diagnoses of anxiety and depression, and even OCD and ADHD that is related to their chronic illness. We know that there are pathophysiologic changes in neurotransmitter balances, and even with the immune mediation, I guess now I'm referring to sort of the PANDAS and PANS, which is sort of the quintessential neuropsychiatric diagnosis. There is an organic reason behind some of these diagnoses. So it's not only situational, but there's some physiology that will support why there's a change in their like level of feeling of anxious or sadness, or some will report anhedonia or disassociation. Some seem to have like amnesic events, right, where they don't recall periods of time. So, I always think about seizures when people say that I don't know what happened to like yesterday morning.
Right. So I really want to dive into what you're talking about at length during this episode. But before we leave what we were just doing, I want to say one more thing. So, you've heard, or listeners have heard me, and you refer to this as medical PTSD. And I think it's a really important concept because that is partly what drives some of these emotional, neuropsychiatric, psychiatric whatever label you want to use for the fact that people have mood and emotional issues related to their illness, which is completely appropriate. Okay. And the problem is that because of the PTSD experience and the gaslighting experience, it can feel or be in fact difficult to discuss some of these diagnoses with patients. At least that's how I feel as a physician, because I don't want them. I'm so nervous. I'm so afraid that they will think, oh, you're just another asshole doctor who thinks I'm, full of it. Sorry. Sunday morning. So, I sort of tread cautiously there, but, that is an issue that needs to be discussed. It's part of the doctor-patient relationship and the medical situation. And talking about anxiety and depression is important. But it's a very kind of a thin ice situation often for the patient, and I tread carefully, but I still think we always need to keep in mind it should be addressed and discussed.
Yeah, I 100% agree with what you just said, and I generally don't even talk about it in the first and often not even the second visit. But at some point, I have to visit it, and I feel strongly about that because I feel like these are young people, often, and especially when we're talking about PANDAS population, which are pediatric. But even, the young adults, or actually any age this applies to, I shouldn't, when you lose a swath of your life, right, to this illness, you cannot help but have PTSD. And so I always, at some point along the way, I always say, when I get you better, or at least feeling better, we're going to have to like deal with the fact that you've lost years of your life, which is
Exactly.
not an easy thing to do. And I think that, we always talk about, adverse childhood events. And in fact, there's lots of literature now that show that adverse childhood events do have a role in chronic illness later on in life. And so while usually when we're referring to adverse childhood events, obviously we're talking more about, well, at least most people are referring to things like physical and sexual abuse. I think having one of these chronic illnesses as a child and not being able to get appropriate care does constitute a childhood adverse event. And so I always say that when they look back on their childhood, it was not a normal childhood. It was spent not feeling well, behaving in ways that they didn't want to behave, and so people reacted accordingly, which is usually not good, and going to doctor's appointments and not going to school and not having friends and not being social. And so now they're young adults and they don't have a normal childhood to sort of draw upon on for any kind of level of confidence and feeling like they can be a productive member of society. And they deal with a lot of PTSD kind of symptoms, frankly. And
Right.
and this applies as well to adults. When you've lost years of your life because of chronic illness, it doesn't go without consequence later on if and when you start to feel better. And at some point, I feel it's my role to sort of help them deal with that trauma, with that PTSD and those symptoms, because that really is like the full recovery, right? So we improve the physical symptoms, and then we have to address the emotional, mental health, psychiatric, whatever, however you want to label them. We have to deal with those symptoms so that life can truly be joyful. And so I think that that's really important. And I agree, like I always sort of try to decide when I'm going to address that. And I'm only discussing it now because I really feel it's important to address for those reasons that I just stated. But I agree with you. Like I tread lightly. I don't
Yeah.
want to bring it up too early on in the relationship. I bring it up when I know that they trust me. When I know that they're going to understand that I don't think that this is related to anxiety. So
Right.
yeah, and so I agree. It's a very careful kind of topic to broach with patients for sure.
Yeah. No, I completely agree. Um, so let's move on
Yeah.
to the second part of this, so to speak, that you were discussing, and I'm going to introduce it by just mentioning for a minute that there's this intersection between what you were just describing and what we were talking about, and the sort of what I'll call biologic aspects of neuropsychiatric illness. Okay, maybe that's not the right term, but that's what I'll say. And I think that intersection is a good example of that are the brain plasticity programs that are out there, which basically take advantage of the fact that we have these phenomenal, elegant, miraculous plastic brains that can be rewired and recircuited and changed by doing a certain kind of work, right? And it's hard to believe. I fully confess that I didn't believe it in the beginning when I had heard about some of these programs like DNRS and Gupta, and somebody said, "Oh, it cured my mast cell activation syndrome." It was like, "Oh, come on, it can't be that can't be true." But it is true, and I've seen it, and I think it speaks to this connection between the sort of PTSD, anxiety, depression, neuropsych stuff, and the fact that there's a biologic explanation for these things.
Yes.
And
There is
and
biology.
if we forget the biologic explanation, this is not going to get better. I mean, I feel very strongly about that,
100% agree with you.
and would take it a step further and say that, and this is a personal bias, and probably I overdo it. I tend to always look for the biologic causes first. I acknowledge the anxiety and the depression, or whatever label you want to use, but I'm going to always say, wait a minute, what's the biologic cause? Is this secondary to infection? Is this true neuroinflammation? Is this a PANDAS-like illness going on? And we can kind of launch into that now, but I just wanted to make that point about this crossing, this
Yeah, I
intersection.
mean, I have no doubt there's a biologic basis to most of these symptoms, if not all of them. And sometimes I question, when patients present to me initially as a new patient and they have these mental health diagnoses, like I just sort of think about them, well, how do they fit into the puzzle of everything else that they're telling me and that I know and that I see? And there's clearly, I mean, again, pandas and pans, which I see it in adults. So I hesitate to always call everything pandas because the P is of course pediatric. So I this is a it doesn't matter the age. I think these are neuropsychiatric disorders. There's a component of neuropsychiatric.
Right. I mean, the official term would be autoimmune encephalopathy, but that's a big long word and it sounds terrifying.
Right.
So
I guess, and that sort of shows the difference in our specialties, because in the neurology world, you can't call anything autoimmune encephalopathy unless like you have clear seizures and like NMDA, receptor antibody and classic antibodies and the autoimmune antibody encephalopathy panels, right? So like, it's very hard to label things autoimmune encephalitis when referring to our patient population, unless there are classic neurologic symptoms, of which, as you know, I don't agree with, but that's sort of how it is. So, but yes, you're right. It's autoimmune encephalitis or autoimmune encephalopathy until otherwise specified.
Right. So the way around is just, I say PANS-like, PANS-like.
I like that. That's good. PANDAS.
PANDAS. I like that even better. Kind of PANS-ish.
And then, as we talked about, when you take a comprehensive history and you take them back to their childhood, very often, although not always, there's clear evidence that there was PANDAS when they were young, and signs and symptoms that, or at least that they were vulnerable to developing this as an adult. And so, so that's why the history, of course, is important, which I think we have sort of beaten to our subscribers.
Well, but it deserves to be beaten endlessly. It deserves to be brought up endlessly. I mean, a classic example in terms of what you just described is frequently or so often a patient will say, I was a normal kid, and then at 8 years old, I suddenly developed these OCD patterns and couldn't stand eating certain foods and became increasingly socially isolated. Well, what happens at 8 years old all of a sudden? Are you telling me some alarm goes off and says, okay, now time to be anxious and psychiatric? Yeah. It's ridiculous, and that's classic Pandish-like.
It totally. I mean, I used to say that all the time. These families would come in, and it was the same story, right? Where their kid was neurotypical, had an infection, and then woke up and was not neurotypical.
Exactly.
And clearly something happened, and yet they were going to doctors, and the doctors not so in the pediatric world. Not only were the kids labeled as anxious and stressed out because of school and had secondary agendas because they wanted to get out of homework, but then there was also where it was blamed on the parenting, right? So, and that, of course, is really terrifying for parents, as we both are. And you can only imagine when a doctor is telling the parents, like, this is your fault, right? Mm-hmm. So, yeah. So anyway, yes, I agree. It was the same story over and over again. So the fact that early on, and probably a little still, but as you know, early on, PANDAS and PANS was a very controversial diagnosis. And, most doctors wouldn't even consider it, like it was thought to be, something that was not a real diagnosis and not worthy of their time and to be treated. I think it's obviously time has changed a little bit.
It hasn't changed a lot. That's not changed a lot.
Well, I mean, I'm just sort of seeing I know that Stanford has a clinic, and so, and there's a lot of great doctors there, immunologists that are working on that particular diagnosis.
All right, so let me amplify what I meant. So it hasn't changed a lot in the sense that if you are a pediatric, and if you have strep throat, which is part of somewhere in the PANDAS acronym, whatever, and you meet certain other criteria, then yes, there's more physicians, more pediatricians in Stanford, et cetera, who will say, oh, you have PANDAS. Okay, but they don't acknowledge mycoplasma. They don't acknowledge chlamydia. They don't acknowledge tick-borne infections. They don't acknowledge it in adults. And I see it in adults over and over and over. And we will now see it in millions of adults as a result of COVID.
Absolutely. So, that's what, long COVID. There's a lot of this.
And even in cases where you and I and most of our colleagues would say, well, of course that's PANDAS, it's still not being acknowledged. I have a close friend who has I'm going to keep this confidential. So I know of a kid, okay, who lives in an area of the country which would be called the medical Mecca, okay, where Stanford is the West Coast Mecca, MGH, Mass General, is the East Coast Mecca. And this kid potentially has access to everything. And not one of these doctors would accept that this kid had PANDAS. And it has taken years for me to convince these people who are not patients that that's what's going on, get this kid on IVIG and do the proper testing. And we're talking about the medical towers, so to speak.
Yeah.
So, I think it's important that people hear this and realize just because some great doctor says, oh, that's not PANDAS, you're just anxious, that doesn't mean that's the case, and just keep looking.
I agree. And I think, I'm not saying that it's changed drastically. I do think that to some extent, like I see dialogue about these diagnoses and any kind of biologic mechanism that might be attributed to the symptoms that, could potentially be treated. And I mean, to me, it's, it's clear this is immune mediated, right? Clear it's immune mediated and it's provoked by infection. And obviously it used to be the group A beta hemolytic streptococci, but now we know it could be just about anything, frankly. I mean, I think any infection is up for grabs. And like all the ones that you mentioned, certainly, and all the ones that our patients seem to be diagnosed with, and so there's such an infection associated immune mediated illness that I think sort of underlies a lot of these symptoms that patients suffer from. And which is why IVIG has been so effective for neuropsychiatric disorders, frankly. And I will say that seems to be at least early on with IVIG therapy, those kinds of symptoms are really the ones to improve initially. And so that's exciting, of course, because those are the most concerning because, they're behavioral, they're mental health wise. And so I think it just allows patients to feel like there's hope, I guess. They sort of get hope.
Yeah.
They're more motivated to pursue further treatments because eventually the IVIG plateaus for the most part. But early on, it's really effective at treating those neuropsychiatric symptoms. And I guess we should clarify. So when we said the anxiety, the depression, but there could be a lot of OCD type behaviors. There could be feelings of irritability. And, in kids, sometimes they act out and they become violent. There could be certainly, obviously, there's a lot of motor kinds of symptoms as well that are housed in sort of this irritability and agitation that's very commonly seen. And so, and those are all considered neuropsychiatric symptoms. So it's not necessarily only like psychiatric diagnoses, I think it's also, there are certain physical components to the psychiatric component. And I think that's why it's referred to as neuropsychiatric. And that actually speaks to some of the studies that were done that showed that there were autoantibodies against antigens and epitopes of the basal ganglia, right, which is sort of part of motor, and the putamen, which also is part of motor function as well as learning function, which I think is interesting. And so they found these autoantibodies that really attack some of these epitopes in the basal ganglia and the caudate, the putamen. And so that's sort of the center where there's dopamine in there. And as we know, the Cunningham's panel focuses on the dopamine receptors and the dopamine pathways. And so that's sort of thought to be related to the motor components of the neuropsychiatric symptoms that these patients will have. So there's clear immune mediation for a lot of these symptoms that affect the brain, and particular certain parts of the brain and certain neurotransmitters of the brain. And I've already focused on the dopamine, but there's some others that are involved. And so that's why immune therapy is really so effective for these patients. And we have seen, years now, IVIG has been shown to be helpful for sure. And now we're seeing that even better than IVIG, plasmapheresis has really upped the game. And I think the more we go down sort of immunotherapies, the more we actually start to look at autoantibodies, the more we're going to learn about what particular autoantibodies we can test for that can be particularly sort of diagnostic of a lot of these disorders, specifically of the neuropsychiatric component of these disorders. Because I think you agree with me that this is not just about one autoantibody, these diseases.
No, and it's not just about one infection. I mean, I think it is a reason why, in my new patient panel, lab workup, and in yours, it's 35 tubes of blood, because I'm looking, I'm going to cast a very wide net, and I'm looking not just at strep, although I do that every time, ASO and DNase, but we look at mycoplasma and chlamydia, and then move on to, if it's appropriate based on history, tick-borne infections. And it's important to emphasize that we are not just talking about children, okay?
Right.
In the history of an adult patient, I may pick up suggestions in their childhood that make me suspicious, but I may not. I mean, they may not give me any childhood clues that they're presenting to me now with a neuroimmune or neuroinflammatory illness that has neuropsychiatric aspects to it, okay? And the only way I will see that or hear that is to start with an open mind about it. Okay. And yes, it's a lot easier if that 8-year-old became OCD at 8 years old, and now I'm meeting a 21-year-old person. That's for me now almost like I don't even need to think about it. I know I have a much clearer idea. But certainly very often I'll meet the adult without the appropriate, or not appropriate, but the suspicious childhood history. And there's other pieces in the history that help. So, you know, if somebody tells me, and you and I have discussed this on these episodes before, if somebody says in the course of taking a history, you know, I had a UTI and some doctor gave me doxycycline and all my anxiety disappeared. It's like, whoa, you know, the light bulbs flash and the bells ring, because that is not the way doxycycline should work.
Right.
Okay. And that is strong suggestion that we once again have an infection-mediated neuroinflammatory illness.
Absolutely.
So it's just such a crucial pathway to go down. I think with almost every patient. And if money were no object, honestly, I'd probably do Cunningham panels on every patient. I would do complete tick-borne disease testing on every patient.
Why are they so expensive?
I don't know why.
They're so expensive, and I often feel badly when I recommend these panels because
I know they're outrageous.
Thousands of dollars. It's not just like a couple of hundred.
Yeah.
Thousands of dollars. Yeah, it's sort of a shame. But, you know, I think at this point, especially for doctors like us who this is what we do, and this is sort of all we do, but I think that, you know, at this point, I don't even need the panels to confirm. It's just nice to have that objective data, especially when I'm trying to apply for IVIG, you know, things like that, or when I'm trying to sort of support why I'm recommending plasmapheresis, which is also expensive. It's nice to have objective data to sort of show that these are what your results show, and this is what we're treating. So, I mean, I think that's important, but it is just so expensive.
Right.
Yeah.
Well, but I think I would say the same argument applies to IVIG and plasmapheresis. If they weren't so expensive, I would be considering them trial of IVIG in almost every patient. But,
right.
You know,
and I also want to point out that I don't think that this is only always infection, right? So, well, yes, I would say probably 90% this is infection associated, but I have still seen these symptoms in patients with like fluoroquinolone toxicity is a perfect example. I have several patients with fluoroquinolone toxicity, and they all have some level of neuropsychiatric symptoms.
And that may be because some of that quinolone or fluoroquinolone toxicity is autoantibody based.
Right.
You know,
exactly.
it's the same fundamental concept.
Absolutely.
Biologic concept.
Yes, but you could test negative for all those infections is my point, but there still might have been some medication. I mean, I actually have 2 patients who have Lariam toxicity, that malarial drug.
Yeah.
So I can give other examples. My point is that I think that there are some medication-induced immune-mediated neuroinflammatory diseases. And so it's not always just an infection. Sometimes it's actually to prevent infection or to treat the infection.
Right.
And so it's important. And then I worry about all our patients with polypharmacy, right? So then I worry, like, and we brought this up before, like polypharmacy is a real thing, as I say all the time. And sometimes these symptoms are related to interactions of the drugs together. And so I think, you know, a real goal is to sort of sometimes look at the medication list, which is, you know, sometimes is very long.
So that I think is a good lead into the other 800-pound gorilla here, which is mast cell activation syndrome. Yeah. So you and I have no doubt, we see over and over that a patient with mast cell degranulation activation can present with profound neuropsych symptoms. I mean, again, it was one of those moments of I didn't believe it till I saw it, until it happened in front of me practically. But you know, patients with intense anxiety, with depression, with cognitive significant cognitive impairment, you name it, name any aspect of neuropsych function you want, and I've seen mast cell activation cause it, and then it gets better when you diagnose and treat appropriately, and that is mind-boggling.
Well, and because B cells are not supposed to sort of cross the blood-brain barrier, but I think the reason why they do and create these autoantibodies is because those mast cells are secreting all these cytokines and enzymes that break down the components of
right.
And allow for basically, you know, autoinflammatory and autoimmune disease within the central nervous system. And so I think the mast cells are a very important component of this. And I don't think that anyone can get better if we don't treat the mast cells. Now, fortunately, IVIG does treat the mast cell activation. So it's sort of like, you know, kill 2 birds with 1 stone, or 5 birds with 1 stone.
Right. Right. But at the same time, or in addition, this whole conversation is for me, an explanation for why we as physicians should always consider medication trials, even if we don't have strong enough evidence, but we have a suspicion. All right. So, in managing patients like we see, these very complex patients who've been through the system, I think we have to have a very high tolerance level as physicians for trying medicines that we can't fully explain why we're trying them. All right. As long as the harm level is fairly low to near zero. So it's a risk-benefit decision, as is everything we do. So, for example, I have zero hesitancy in every patient to give them a trial at a minimum of an H1, H2 blocker.
Right.
And see what happens. And over, a patient will contact me a week later on messaging and say, my brain is clear. I don't understand it. Or trial other meds. I'm a little more cautious with antibiotics, but I still think it has to be done. I think, go out on a limb and say, even after having gone through several other things, a short course of high-dose steroids can sometimes clarify the picture remarkably. So it's the kind of medicine you and I are forced to practice, but it works. I mean, we learn things and we help people get better as a result.
Yeah, it works often. And I think that for sure people have transient improvements. There's no question all the time, but eventually the symptoms seem to flare again. And so then we have to circle back and figure out what's next. I think that's the magic of the body, right? I think you shut down a certain pathway, the body will circumvent that pathway, and eventually another pathway will rear its ugly head and the symptoms then start to recur, or the medication effect just plateaus, as IVIG often does. But I think that too is because the body has so many different pathways to try to accomplish something that's even not healthy for it, that if it's in the throes of this inflammation, it just sort of finds its way back towards like what we refer to as the cell danger response, right? Because it takes a lot to send that message that there is no more danger, that the cells can calm down.
Right.
So it's not, people always say, how do we just sort of, get ourselves out of that cell danger response? And it's not that easy. It's not that easy. You can do it just transiently, but to really send that message home so that that pathway is truly shut down and no other pathway sort of comes up, you have to really send that message strong. And that usually takes several medications and time, frankly. So that's why I always say trial and error with different medications.
So you bring up a really important point that I want to spend some time on. Okay. So when we use IVIG, plasmapheresis, steroids, Humira, Remicade, all the fancy multi-tens of thousands of dollars biologics. At the end of the day, my argument and my concern and my frustration is that we are dealing with the downstream inflammatory symptoms and pathology, and we are not addressing what's causing the problem. And again, fully disclose my bias here. That cause of the problem is infection in virtually every case. So, it's part of what's happened in medicine with Big Pharma. Big Pharma's done amazing stuff, and I know I diss them all the time, but without them, we'd be back in the dark ages in terms of the drugs that they produce. But
that's our big complaint.
What?
They're too greedy.
They're too greedy, but they also, that greed drives the way they do their research. So, they develop a biologic drug like Humira for Crohn's disease without addressing the fact that Crohn's disease is actually a microbiome, leaky gut, infection-mediated inflammatory event. And so if you stop your Humira and you haven't dealt with the underlying problem, you have your Crohn's disease. And I fully acknowledge that's the same thing for you and I when we give steroids or IVIG or plasmapheresis. And sometimes that's all we can do. And I understand that. And more than sometimes, frequently. But we should never let those tools blind us to the fact that we need to look for the underlying cause. And, we've evolved for millions of years in this microbe-ridden environment, which also helped us to evolve and stay alive, but is always there potentially driving problems, ranging from, the microbiome, which is, quote, normal, but can get out of control, to all the virus and bacteria that are out there. And the more you read and the more you look at the research, the more it becomes clear that, in fact, all of the majority of these illnesses, whether you call them rheumatologic, connective tissue, autoimmune, are driven by infection. Mm-hmm. And if we don't find those infections and try to treat them, the patient will be stuck on the secondary treatment, which is the broad quotes, anti-inflammatory treatment. My little rant.
I completely agree with all that you said. I mean, I think, I think there are philosophers that could probably, articulate sort of this, the fact that microbes, we've evolved with them, they've served us well, but they're also now not serving us well.
No, they still serve us well, but we forget that they do other things.
Right. No, exactly. And I have this feeling like there's something very articulate and profound about that notion that I'm not smart enough to come up with a good phrase or a good quote about it.
Right.
But there's some beauty in that, right? And that's why I think we have to find that harmony, that harmonious way of living with these microbes. And I think that the more we embrace this idea that they could harm us, that they have that potential to harm us, especially in light of, and that I preach this all the time, our environment just keeps getting dirtier and dirtier. So we are not nearly as resilient maybe as we were years ago. And, I say that knowing that, obviously our lifespans yet have increased, but that's because of medical interventions, right? So we have a ton of phenomenal medical interventions to keep us alive these days. And so I think that there's just something, I don't know if it's wrong or if it's right sometimes about how our medical system has sort of worked. We're so off the topic now.
It's all right. It's a story of our life together on this program.
But when you were talking, I was realizing this sort of this profound sense of we need to find this level of harmony for our human bodies and our human minds and our human souls that can coexist with all the things in the environment, including all those pathogens that just really want to kill us.
Well, based on the recent decisions, I'm sure the Supreme Court agrees with you.
Right. That is true. Let's
right.
Political.
Yes, I know, but I can't help. All right.
All that. So anyway. Okay, let's sort of back to. We meant to talk about the neuropsychiatric symptoms. So I do think that the fact that there have been these autoantibodies that have been found to be part of, like I said, the basal ganglia, the putamen, the caudate nucleus, but also the dopamine receptors. I think that's an important point. And I think that it's not as easy sometimes as just sort of measuring levels of dopamine, because there is not a clear correlation between having an antibody against the dopamine receptor and then how much dopamine is in the body. And dopaminergic neurons are very complex, as all neurons are. And so I think there's a lot of research still to be done, but there is a clear biologic problem that underlies these neuropsychiatric symptoms, but yet responsive to immunotherapy.
Right.
Point. And so, while we can't yet explain every detail as to why this is happening, I think that some of the research is really pointing in this direction, but we have some treatment. And I always say it doesn't change treatment that we offer, which is immunotherapies. And I think that's...
Yeah, and I'm not trying to say it's one or the other, meaning infection versus immune therapies. I'm just saying immune therapies buy us time, so to speak, to look for and try to deal with the underlying cause, or we are stuck only using the immune therapies. And very often that's the case. I understand that, but I think it's clear to me, and clear to many other physicians, and become increasingly clear to more physicians as a result of COVID, that reactivated infection is a thing. It's not some fantasy from Lyme literate doctors, or from ILADs, or from people who feel Lyme with their hands, right? It is a real goddamn thing. These diseases can reactivate. And we see it over and over when there's an immune challenge, whether it's COVID or trauma or surgery or emotional, or even another infection. So you have a COVID patient, long COVID patient comes in, if you run the appropriate tests, they have EBV viremia, they have Borrelia, which is Lyme, and Bartonella showing up, and they have ASO and DNA showing some active strep infection. Where did all that come from? Right. And it's such a key concept. And, mainstream still hasn't bought into it, but I think there's been movement because of COVID. And it's just so important for patients, for people who are ill, to understand this and look for physicians who will will search into that.
Are you at the point, do you think that everyone should just be tested for infectious exposure?
Yes.
Really? And I'm serious. Like, I mean, we
Well,
should
that's
all
what I was saying.
know our infectious burden, right? Don't you think?
Yes. The problem is that if you are feeling healthy and are healthy and not challenged immunologically, some of that testing may show nothing, right? Because everything may be latent and there may not be antibodies. Most of the testing is looking for fingerprints, which are the antibodies, right? That's right.
No, it's not. Yeah, that makes good sense. I'm just
So,
thinking about all these longevity people who are like doing all kinds of things to sort of keep them, to reverse the
right.
hands of time.
Yeah.
That if they understood their infectious burden, that if that would contribute at all, maybe not. I don't know.
Well, it would be, it probably would certainly be interesting and, help us understand more.
Yeah.
I guess the argument I'm making, or that I can think about, is we grow up, we live our lives surrounded by organisms.
Right.
So we all have them in our body. It's why I have trouble sometimes with all the mold arguments, because mold is everywhere, but most of us aren't sick from mold. So,
Right.
so why do we get sick? And we can go into that in a second if you want. But so your idea makes sense, testing everybody, but presumably everybody may not show antibody evidence of active infection because they don't have active infection,
Right.
but it may reactivate at any moment.
But you've advocated for the PCR testing, but so that would still be present if we had been exposed and they're just latent infection.
No, not necessarily, because if you PCR, it basically means they're emic. They're either viremic or bacteremic. It's in the blood. That's how PCR is only looking at the blood.
Right, but
Right.
if it's in the tissue, I mean,
Well, if you can get tissue biopsies, you can see. I mean, Ed Breitschwart at North Carolina State has done tissue biopsies. Bob Mazziani has shown it, and we can see organisms in the tissue at the same time the patient may be not bacteremic and not even have antibodies present. I'm getting really off topic, but one of the confounding things in Bartonella medicine, if there is such a thing, is that often the antibody testing, the serology, is negative. The PCR or the FISH is positive. You treat the patient, and all of a sudden the antibody becomes positive. And again, I didn't believe it when Mazziani told me that the first time. It's absolutely true. You see it over and over and over. So it flies in the face of everything that you and I and every other physician is taught in medical school, which is we mount an antibody response to an infection. Here's the infection, and there's no antibody response. Well, these bugs are not stupid. They took millions of years to evolve and figure out ways to hide from our immune systems, to